Hello, everyone. Welcome. Welcome to today's um, program. We are going to begin in just a moment. We're just going to give the attendees a few more seconds to get signed in and settled in. Meanwhile, feel free to adjust your view accordingly, and then we'll get started in just a half a minute. Okay, it looks like our attendee list is still growing, even though it's 2:02. Um, I'm going to go ahead and get started for today. So, hello, everyone. Good afternoon, and welcome to the UT Southwestern's O'Donnell Brain Institute's Total Care for PD community event. Today is the first of our new series titled Ask Your Doctor, and we are excited to have you with us today. For those that have attended our previous virtual events, you'll notice some changes in how things work because we've upgraded from meeting to the webinar version of the Zoom application. The biggest change for our audience is in the way you can interact with the speaker and host during today's event. Because your participation is vital to this program, please listen to here's how you can share your questions and ideas. Take a moment now, if you will, to find the chat and the raise hand icons located in the bottom of your screen. When you click on chat, a window will open for you to type in your question or comment. You may do this anytime during the presentation because the chat activity will be monitored and our moderator, Dr. Sood, will present the question to the speaker at the appropriate time. Should you prefer to speak rather than type, you may click the raise hand button. This will send a signal to the moderator and you will receive a request to click unmute when they are ready to receive questions. You may speak once you've answered the request to unmute. An important reminder for today's session is being recorded. By participating, you provide your consent to be included in the recording. If you prefer not to be recorded, we recommend using the chat feature instead of speaking live. Now, with the housekeeping complete, I'm pleased to turn things over to Dr. Sood to begin today's presentation.
Thank you, Janice. Hello, everyone. My name is Anubha Sood, and I lead the Total Care Program for Parkinson's disease here at UT Southwestern Medical Center. Total Care is a supportive care initiative, and we offer informational, educational, and community building opportunities to support people with Parkinson's in living well and better with the disease. You may learn about our events and all our offerings by visiting our webpage or writing to us. You can write to me, you can write to Janice, or you can write to us at our program email, which is obitotalcareprogram@utsouthwestern.edu. At the end of this presentation, we do have a very short survey, so please tell us how you find this presentation. And before we begin this presentation, I would like to thank our donors who make all of this programming possible. With that, I'm going to turn it over to Dr. Hirczy. He is Assistant Professor of Neurology in the Movement Disorders section here at UT Southwestern, and he's going to talk to us about side effects of PD medications. So welcome and thank you, Dr. Hirczy.
Thank you for having me, and I'm excited to be here virtually, talking with all of y'all. So let me pull up my slides. Okay, so I think this is the crucial topic and is very interesting, but I'm going to talk about side effects of Parkinson's disease medications, and it will pass. So first off, what are we trying to treat in Parkinson's disease? I think as a movement disorders doctor, we talk a lot about motor dysfunction, and we talk about tremor and slowness and stiffness, which we call rigidity in the chart, and shuffling gait and mobility changes. And that's kind of our dominant focus. And we hope to use medications and neuromodulation and therapies to help reduce the severity of those symptoms. But what is not talked about as much, but is getting more traction and is very important for people's quality of life, is the autonomic dysfunction that is present, which is all of those things that happen when that you don't need to think about to have happen. The nervous system controls your bowels and bladder and controls your blood vessels. So constipation and dizziness or orthostatic hypotension are also things that we treat in Parkinson's disease. And then another lumped category is neuropsychiatric dysfunction. So people with Parkinson's disease, depending on the person, that can have memory and thinking changes. Medical terminology that are used are executive and visual spatial deficits. And then depression, anxiety, impulse control disorders, visual hallucinations where things are seen that other people don't see, misperceptions where people see things that they thought were there, but it turns out to be another thing. And so on the right, there's this useful little graph, which I like to show and talk about, which is basically showing these principal axes. So autonomic dysfunction on one and cognitive on another, and motor dysfunction on another. And so sometimes the treatments that we give for one thing, like motor dysfunction, are going to actually change things on other sides. So in here for this graphic, on the left part of it, there's near asymptomatic, so scores of 0. In the middle, this is someone who's very well controlled and has almost no autonomic, motor, or cognitive symptoms. And then here on the right, this is more severe symptoms where there's more motor, cognitive, and autonomic dysfunction throughout. And so I think that's a useful framework to think about when we're talking about the side effects of these medications. Well, so what are we doing? Why are we adding them? And what can it cause? And the next thing that's useful to talk about as a framework when we're dealing with this is, well, what limits our ability to treat Parkinson's disease? What limits our ability to use Sinemet or carbidopa-levodopa and various dopaminergics to help with Parkinson's. And so the other key component is therapeutic window. And this is a graph that comes up a lot. And basically on the y-axis here, there's blood levels of levodopa or dopamine effect. And on the x is kind of time, and time, long scale time. So we should focus first on the left side, which is early in Parkinson's, early in motor disease. We give people Sinemet or carbidopa-levodopa usually, and you take it, and after a certain amount of time, maybe 30 minutes, maybe an hour, you start absorbing it. It goes in your bloodstream, it gets into your brain, and then you start to have its effects manifest, and people feel good. And this green area is this good feeling area. So the purple line shows how the dopamine level rises after taking the medication. And then as time goes, your body clears the medication or it gets used up, and then the levels drop down. And early on, it's usually you just stay in this green period. So there are big changes in the levels of dopamine in your blood, but your brain actually is able to store some of it, and it just feels generally good. So you don't notice an on or an off effect that the doctors talk a lot about. It's just, I feel better after being on levodopa after a day or a week or a month. Things just seem better. But as things progress and people can develop motor fluctuations, and what that means is this little purple line, it continues, you still absorb it, But sometimes you overshoot and the levels rise too fast and we go into this peak dose area and too much dopamine is around and your brain doesn't have a way to utilize that in a productive manner and it starts having dyskinesia. There's just too much medication. It starts to have extra movement. And the Parkinson's medication of Cinemat, you're thinking that it's helping promote movement and now it's over promoting movement. But again, as your body clears it, it comes back down into a good state. And then it's possible that if we were off on both ends, then it goes too far down. And then we get what we call wearing off, where there's not enough Cinemet anymore. And you feel too slow or too shaky, or your walking and movements are worsened. But usually there isn't any of the wiggling dyskinesia. And this kind of goes up and down, and it gets more notable over time. And this principle of the therapeutic window, it's actually present in all of those three systems that I was kind of talking about initially. So you can have a therapeutic window for autonomic symptoms and for movement symptoms and for cognition. And they're not exactly the same. So each kind of area can actually have different window, different doses that seem to work for them. And even different parts of the body for the same symptom like tremor, they can actually have different levels, different areas that make them happy. And so this is one of the big limitations. And so the last one is kind of talking about that same thing about the three axis, but what limits our ability is the complexity of dopamine. Dopamine receptors are throughout the body. So on the left is this little graphic showing the areas where there are dopamine receptors, and they're in the retina, blood vessels, heart, and adrenal glands, and the kidney, and the gut. And they're actually the very same receptors that are present in your brain. So dopamine goes all over the place when it can do things that we don't want it to do. And then in the brain itself, there are different kinds of pathways that are activated and utilize dopamine. And so it's hard because sometimes we're focusing on one thing that we want to fix, but it's getting to the other pathways that didn't really need it and overactivating them, or we're trying to fix one area and it's not enough for that area. So that's the challenge of using a pharmacologic medication or just medication or interventions in general to help with Parkinson's disease and to treat Parkinson's disease. Okay, and then here's just a little graphic of what this really looks like. So that was this graphic before, and here we have an individual pre-treatment that says, okay, I don't have a lot of autonomic dysfunction. That's actually doing well. Cognition is okay. There's a little bit, but not too bad. And then, oh yeah, my motor symptoms are pretty notable. It's pretty bothersome. Something should be done. And so you tell these things to your movement disorder doctor or your neurologist. And we say, okay, well, let's add some Cinemat that treats motor symptoms. And when we do that, we have this little arrow and we push this down and we say, oh, okay, solve those motor symptoms. And when things are more advanced and hard, this is kind of what happens some of the time. We'll see that, okay, motor symptoms are better now, but now we're starting to feel that, oh, I'm kind of sleepy, or I'm a little hazy, or, oh, I'm having more blood pressure problems going on, that it's getting too low. And so in advanced stages, there is this kind of push and pull where we do some intervention and there are side effects from that intervention that come out the other sides and the other systems that are involved. Okay, so that's the biggest topic that I think is helpful, is talking about the side effects that come from dopamine and dopaminergic therapies, because those are pretty much universal across the board about when a neurologist is trying to fix tremor or movement issues. These side effects come up on all of these medications, almost all, and it's sometimes just a matter of degree. And then at the end, I'll talk a little bit about those other side effects that can happen from some of the medications that are not related to just dopamine. And so the number one side effect that comes up, and it's often at the beginning, but can continue, is nausea. So nausea, the sensation of some discomfort associated with the need to vomit. So I think almost all of us and have felt this side symptom, and not a fair number experience this with Sinemet. And we think it's related to the fact that in your gut, there are lots of dopamine receptors, and they have to get used to having this medication around. And so usually this happens shortly after taking dopamine, just in an order of minutes after, and then it kind of goes away. And usually it's when it started or there's some kind of change where the medication is increased and then it gets tolerated. Your gut learns how to deal with it and doesn't get that sensitivity. But it is a bothersome symptom. There are difficulties with increasing medication in certain people. It's very challenging to get to doses that are supposed to help with their movement symptoms because it's just there's too much nausea. And then it can limit how much people eat when they're on the medication. And so what do we do when we are finding that there's nausea? And so the thing that is kind of going to be reiterated for these symptoms is, well, when does this happen? And what relation does it have to my medications? And mostly it's the dopamine medications, but also other medications it's helpful to know. And the standard things that are easy to do are to take the medication with a full glass of water, applesauce, crackers, and kind of radiating it upwards to deal with that. And then talking to your clinician about other changes that can be done. So there's another medication called Lodocin, which is actually just carbidopa, which is inside that carbidopa-levodopa that you see on most of those, the Sinemet and Rytary and Crexont medications. There's a way of just adding extra carbidopa. And extra carbidopa just blocks the bad side effects that come from dopamine in the periphery, in the outside of the brain and in the body. And then there are the options of giving you non-oral formulations. Some things can be given through a patch or through a pump and skip the gut. And sometimes that helps with nausea. And then there are non-dopaminergic therapies, which don't change directly dopamine. And so sometimes that doesn't cause nausea. And then sometimes the last resort that people talk about is actually adding protein to medication time. So sometimes it just kind of comes down to that, and we try adding meals. Okay. The next thing to talk about in this area is dyskinesia, and this comes up a lot. And the definition of dyskinesia are movements that are writhing or dance-like, and they're usually non-purposeful, and they're related to dopamine treatments in the vast majority of cases. And the timing, the typical timing is peak dose. So this happens shortly after dopamine is given, and other symptoms are usually well controlled when this is occurring from a motor perspective. So if someone has a tremor, a rest tremor that bothers them, this movement usually doesn't happen at the same time that tremor is going on. It's usually only when that tremor seems to be really well controlled, this is there. Now, there are some other rare versions called diphasic or off state, which happen at different times in the cycle, but they still have the same kind of appearance. And the impact of dyskinesia is usually that it's initially not bothersome, but people start to find it more and more bothersome, and it can be a stressor. And then functionally, if it's affecting people's legs, balance can be impaired. So when someone is considering whether they're having dyskinesia or noting it, it's helpful for the movement disorder doctor and for others to, when reviewing this, to have videos of these movements and to, again, record when did these happen and how are they related to the medication? Is it really 30 minutes or an hour after, or is it happening at other times? Is this different from your other movements that you've had before? Sometimes there's a struggle of describing tremor and dyskinesia, and sometimes people have movements that kind of blend and mix the two. So videos are very helpful and timing is very helpful. And then sometimes, depending on what your clinician says, you can try modulation of your medication. So if you have PRNs allowed or as needed, Sinemet, or you have Inbrija, you can see if this kind of changes. If you take a little bit more dopamine, does it get worse? Or if you happen to miss or happen to delay a medication, does it get better? Well, that can be helpful. And so talking to your clinician, of course, after you've collected a little bit of initial data is very useful because there are interventions for it. So dyskinesia can be improved by either decreasing the total dose of dopaminergic medications that you're given, or splitting your medications up into long, or giving you long-acting formulations instead of short-acting. And then other medications can be added that counteract dyskinesia, like amantadine. And if it's not really that bothersome and then it's just noted, sometimes monitoring is sufficient. You can just say, oh, I have it, I know that it's there, and we'll just leave it be and see if it changes. Okay, the next big one is orthostatic hypotension. So there's a formal definition for this, but basically it's lightheadedness when you stand. So as I talked before, they're in your blood vessels, and in your brain, there are dopamine receptors, and dopamine plays a role in heart determining what rate your heart goes and how tight the vessels are. And so when there's dysfunction present, the dopamine medications usually can lower blood pressures more. So people will experience lightheadedness. That's the classic symptom, but not everyone experiences that. They can actually, what's more sensitive is the narrowing of your visual field, so kind of blurring on the periphery when you stand up, or seeing stars. And sometimes people just notice that they have neck or shoulder pain, or that their symptoms, their other symptoms, that they feel hazy, or that their tremor or their motor symptoms, their walking gets worse. And usually this is related to your position. So these symptoms don't happen when you're laying down, but then they happen when you stand. And there's some timing that can be helpful figuring this out. Usually mornings are tougher. After prolonged periods, laying down or not being active and then suddenly getting up, that can trigger these kinds of symptoms. And then hot weather, hot tubs, showers, those things usually make those things worse. And also seeing, again, timing. So usually this is a side effect that happens after receiving the medications, usually 30 minutes to an hour. And the impact, it's a big impact. So sometimes this kind of symptoms is causing problems with balance and being lightheaded. Usually there's a risk of having a fall or passing out, or not doing the activities that you want to do or that we recommend doing because it's hard to do them, and then you just don't feel good when you're standing. And so there are various interventions for this. So if you suspect that they're having this lightheadedness and orthostatic hypotension, then checking blood pressures is the first thing to do. And the standing and seated blood pressures are important, or laying down are the best ones, with then standing about a minute and then 3 minutes after, or just 2 minutes after, depending on what the neurologist in your clinic tells you to do. And then, again, like with the others, record when it happens in relation to other symptoms, in relation to your medications. You can test non-invasive interventions to see if it helps, like, oh, if I drink more fluids, if I have a little bit of a salty snack, if I wear compression stockings, does this get better? And then you can, again, as always, talk with your clinician about medication changes. So the simple thing, if possible, is to decrease or remove blood pressure lowering medications, because you might not need them anymore, because dopamine and your Sinemet or your other medications are lowering your blood pressures. And so maybe now you used to take amlodipine or some blood pressure medication, but you no longer need that. And so that's usually a nice one when you can just take something away. If that's not an option, then decreasing or lowering dopamine medications, if your motor symptoms and other symptoms are well controlled, is a reasonable thing to do. Or splitting or changing to long-acting formulations can work. And then when none of those things really work and compression stockings and other things don't work, then adding blood pressure elevating medications like droxidopa, midodrine, and fludrocortisone can help. And then this is a broad category, but neuropsychiatric worsening. So the toxic effect of dopamine on cognitive networks resulting in dysfunction. And so this is actually a bunch of different side effects and symptoms. So But some of the common ones are an increased need for sleep or sleep attacks, sudden uncontrollable urges to sleep, confusion, difficulties planning or conversing, impulsivity and addiction, impulse control disorders, and visual hallucinations and misperceptions. They all lump into this category. And usually these happen when your dopamine medications are increased, when the doses are increased. But sometimes it happens just kind of over time, and their impact is substantial and reduces quality of life and function. So when these things happen and are noticing them, first thing to think about is mitigating risk. So what happens if you were to have a sleep attack while driving, or if you were to get confused while driving, if you're cutting a tree down, so seeing what kind of activities and if this symptom were to happen, because these are frequently a little bit unpredictable, even if it is usually triggered by some change in the dopaminergic pathways and increasing the doses. It's not just, the next day necessarily. It can happen within the month. And then seeing if there's any other reason for it. So again, checking your blood pressure. Sometimes these symptoms can come from more so in the sleep category, from those orthostatic dysfunction that can happen. And then recording again, when does this happen in relation to other symptoms, and talking with your clinician about medication changes. Again, for these side effects, decreasing or lowering dopamine medications may be a reasonable way to go. Switching from long-acting dopaminergic medications sometimes actually helps to shorter acting. Adding medications to counter these symptoms, like medications for memory, medication for wakefulness, sometimes those are useful as well. And then impulsivity and addiction and things like that, those ICDs sometimes going and getting a referral to the psychiatrists for additional help can be beneficial. And then there are also psychiatric medications that can be utilized for these various symptoms. So we touched upon nausea, dyskinesia, orthostatic hypotension, lightheadedness from standing, neuropsychiatric worsening, dopamine dysregulation, which is another thing that happens where we just do more and more dopamine, and then somnolence, impulse control, visual hallucinations, and then the last thing, peripheral edema can be a dopaminergic side effect as well. A lot of swelling can happen in some of these medications, usually in your legs. And some of it's from Parkinson's and some from the medications themselves. And so a lot of these things, it's tough. You have to figure out, well, is this the Parkinson's or is it the medication? And sometimes some of these are a combination of both. And quickly, just want to touch upon non-dopaminergic effects or some common effects of some of these drugs that we utilize in Parkinson's disease and their side effects. So this is the class, catecholaminergic methyltransferase, O-methyltransferases. The medications in this class, like entacapone, tolcapone, and opicapone, and some of the common side effects, orange urine with entacapone, liver injuries. So your primary care doctor checks your CBC and CMP, and this medication of tolcapone is not utilized anymore, really. And then opicapone can come with diarrhea. And so drugs can have effects outside of just the dopamine-related replacement pathway, and these are some of those effects. Amantadine, one of the things to touch upon, foot and leg swelling, as well as this libido reticularis pattern that you see on the upper left, which is the A picture, has libido reticularis, and this is, I think, after they stopped it and it kind of improved. And amantadine, which again is used for dyskinesia, can cause more leg swelling, and this is the peripheral edema picture. And then amantadine also can sometimes cause confusion, insomnia, and myoclonus is twitching effectively. So sometimes people say, "Oh, I have more tremor on amantadine," but it's notable to know, is it different? Is it the same kind of movement, or something new is coming in? And then acetylcholinesterase inhibitors are a class used for mostly memory and thinking, but sometimes we use it for freezing of gait. Sometimes we use it for sleep disturbances. These medications include donepezil or Aricept, rivastigmine or Exelon, galantamine or Razodine. And the common side effects there are nausea and other GI effects, weight loss, slowed heart rate, and other cardiac rhythm effects. So in people with cardiac disease, frequently we ask your cardiologist, is it okay to use these medications because the effects are small, but sometimes meaningful, but we never want to do something like that, give you a small benefit if it's going to cause some big side effects. And then vivid dreams are reported as well. And then anticholinergics are a medication that we don't use too much anymore, but sometimes it is something that we try, usually in the sense of controlling tremor, and trihexyphenidyl is the big one that we use there, Artane, but some people may try benstropine. And then oxybutynin and Vesicare, these are medications for overactive bladder. They reduce the frequency that you urinate, but they can have side effects such as constipation, dry mouth, urinary retention, blurred vision, confusion, and cognitive impairment. So those are things to watch out for, and these medications are not always tolerated very well in individuals who have a mild cognitive difficulties they notice, or they feel a little hazier than they used to. Just be careful and watch out and see if these things come up. But with all of that, that was a whirlwind tour, but I wanted to have time to answer questions that came up and address anything. Okay.
Awesome. Thank you so much, Dr. Hirczy. I do see some people raising hands. And then we have some questions already on our chat. You know what? I am going to go to Mac in a bit, but first I'm going to ask the question that's here on chat, which is, it seems to me that my dyskinesia has no consistency, but I'm willing to try adjusting my carbidopa dosages. How often should I expect to be able to meet with my neurologist at UT Southwestern, weekly, monthly?
So this is challenging, and it's based on your neurologist and what their discretion is. I'll say it's very unlikely that you'll have a weekly visit, but everyone's different. Sometimes people will do when things are acting up significantly. Sometimes there's a monthly visit for a little bit. But I will say that the standard kind of comes down to, every 3 months, or 6 months. So the thing is that you don't have to see your neurologist every time to talk about these things. These things can also be managed depending on your neurologist take, virtually or through the chart. So if they've seen it and they know what it is, and we have some interventions and you can provide videos and things like that of it, then we should be able to address that without having to see you every week.
Thank you. I'm going to move to Mac and allow talk. Yes, Mac. Oh, let's see. I wonder, do you want to try, Mac, to unmute yourself? Because it seems like.
How about now?
Okay, there you go.
That be me.
Yes, we can.
Okay. Are you familiar with a monitoring program called Neuro RPMS or NPS?
TMS. No, but tell me more.
Working with your iWatch and your iPhone. And I've been started on it a long time ago. I was on Rytary until about first of the year, and they decided to quit funding it and it ended that program. So I've been on Cremont, CRE.
Croissant.
Yeah. Since then, and I can say, any given time of the day, any given day, various symptoms show up, and I don't recognize them necessarily. But the way they monitor and track, I think could be a tremendous benefit.
Yeah.
Because you at least go back and have something to review. Now I've had iWatch and iPhone problems that kind of messed up the thing. So I haven't had a long, I had about 6 months before with Rytary, and it was very, very informative.
Yeah.
But you might look at it, I think the key to it, what I see is monitoring of when these things happen. And it was, when you're driving, when you're doing this or doing that. And it would be nice if you could add to that program so you chart it when you get confusion, when you get this, when you get that. Sometimes just my eyelids get so heavy in the middle of the day, I can't keep my eyes open. Or I just feel like if I don't lay down and go to sleep, poof, or just, and then I can't sleep at night.
Yeah, so that's excellent, and thank you for bringing that up. That's actually something that we're going to try to pilot soon with and it's a different app, but Strive PD and Rune Labs. So there are several of these apps that use the Apple Watch, and the Apple Watch has this movement toolkit. And so it helps track tremor and dyskinesia and how you're walking, several different metrics of that, and your heart rates. And so that's where this is all going. The feel, instead of having to scribble down your notes in your book, your watch will passively collect all of this, as well as you will be able to put in the app or timestamp or however you want. Here, I had this symptom at this point, and this symptom, and then it aggregates that and presents it to your clinician for easy review. And so UT Southwestern, we're working to have that very shortly. And then we also are just more interested in seeing what other apps kind of get developed as well. So, yep, I think that app, there are various ones that are free for you. So I encourage people to try them out. Just note that read over. There are privacy issues that can happen with some of them, and everyone has different tolerabilities on what they're willing to share with people. So be informed, but I think they can be very useful.
Okay, we have another question here. How do you evaluate whether your dosage of carbidopa levodopa is the correct strength?
Yeah, so this is a team effort. And so it's not the easiest, and that's why there's a subspecialty for this. So it's easy to know when someone feels very off, and then kind of they take the medication, they feel better and not as bad. But how to know exactly what the right dose is? And the answer is probably that there are lots of right doses, depending on the period. And there's this middle area where I showed the graph of there's a middle where things are okay and good, but it's hard to know for certain. And then your movement disorder doctor, if you're too high, will look and see for side effects. So once you start seeing side effects, then we say, oh, that doesn't sound like the right dose. If you start getting dyskinetic, usually you're not going to get any more motor benefit after you're dyskinetic. Caveats, there are always caveats, is one side of your body could be dyskinetic and the other still feels off, and it's kind of about figuring out what matters to you most at that point. But side effects really, really help us at the top. And if people are telling me, I'm really dizzy and I'm super nauseated, I just feel crummy and I'm foggy, then I know that, I shouldn't be adding more. I shouldn't be giving you more. And then at the bottom, when people feel like, yeah, I have tons of tremor, and when I take the medication, that gets better and I'm no longer bothered, then I know that, okay, that's the floor. But this middle area is hard because there are other things that happen, like arthritis or neck problems or neuropathy, like all of these little other things, they can make you look worse from a Parkinson's standpoint, but they're not going to get better by throwing dopamine at it. And so it's a team process of figuring it out. There's a lot of trial and error too. So okay, well, if I try giving myself a little bit more under my doctor's observation, does that get better or not? Or, okay, let me go and see my doctor and see what the videos or what they think. Did this really change? And you're not committed to one thing. So, if you tried it, you're not forever going to be on that higher dose. As it didn't really do anything, then don't stay on that higher dose. Go back to what was working and did just as well.
Thank you. I am going to, before I go back to the questions on here, I am going to give a chance to those who actually posted questions ahead of this session. And I'm going to ask a couple from there. I have the list here. So there's one question about new advancements in medications. And one particular one is ibogaine. I don't know if I'm pronouncing it right. If you have any thoughts on that, Dr. Hirczy?
Yeah, so I didn't know about that until I received that question. And it looks like it's kind of a psychogenic medication. And so from brief review, I don't have any evidence of using it for people with Parkinson's. It's not approved. And I think it there are some risks that come with that. So I saw the cardiotoxicity and other things. So again, there's always research going on. They're always trying to figure out if there's some new thing that might be helpful, but I would defer to, unless you're in a clinical trial for it, or pretty much I would refer to a clinical trial if that's something, but I'm not using that in clinical practice.
How can physical exercise programs offset medication side effects?
Yeah, so this is an interesting question. And so we know that people who exercise in Parkinson's do better, and that it will help with managing some things. And we usually talk mostly about it managing the primate for the Parkinson's and the symptoms of Parkinson's, and not so much addressing the side effects. But it can, like with orthostasis, so dizziness that comes from standing, people who have been laying flat for a long time in an ICU, who don't have Parkinson's, can have this dysfunction too. And so physical activity and getting your muscles to be stronger and to pump better and get your heart to pump better can manage that. So it will give you more of a reserve. For things like dyskinesia, it's tough because it's as far as I know, it doesn't really change what's happening. There's just too much dopamine in your brain at that time, and you can exercise it, and perhaps in some people you can exercise it off. Like you can use it up by doing activity. But in the most cases, it's not going to get rid of it. And it might be a little bit more notable because when people are moving, they'll have more dyskinesia. But it's anyway. So I would encourage people to continue their exercise and physical activity, and it might address some of the side effects or the things that come from Parkinson's disease, the symptoms of it.
Thank you. There's a question about a specific medication, Nuplazid, and what the benefits versus side effects are in consideration to discontinuing medication if there is peripheral edema.
Yeah, so everything is a balance. Things come with their side effects, and it's what are they trying to target? Usually when Nuplazid is given, there are notable psychiatric changes that are happening, like people are seeing bothersome visual hallucinations, or they're becoming fixated on things, we have Parkinson's disease psychosis that is being treated with Nuplazid. And so in those cases, it's a dialogue with your clinician about the side effects, and do we feel that it's coming from the medication? Was it clearly that it happened after? Because again, symptoms versus side effects, it's challenging. And the other thing is, okay, if there's edema, is it manageable? So can you wear compression stockings or elevate your legs or have physical activity to improve it or reduce salt? These things could be done. And then the thing I do want to talk about there is that in general, we don't recommend diuretics or medication, water pills to get rid of this edema that's in your feet. Sometimes this is done in primary care. But usually it just takes blood out of it takes water out of your blood first, and people can get lightheaded and more orthostatic on that. So it's a nuanced discussion, and it depends on your symptoms and how bad the side effects are.
I'm going to ask one last question from this list and go to everyone who's raising their hands. Can dystonia be controlled without going to DBS?
Yeah, so we have things that we can do. It's a matter of control. It's challenging on that wording. So we have Botox that can be helpful for dystonia depending on the locations. We can give Botox, and that can be very beneficial for some people, and some people stay for years or for their lifetime on just receiving Botox, especially if it's just in one area, like, oh, just their left foot, their toes curl and it kind of bends in a little bit. If it's isolated, if there's dystonia throughout your body, it's tougher because it's hard to give Botox everywhere. And then there's the whole discussion about medications and if it's causing. So some people get dystonias when they take too much of their dopaminergics. They get an on dystonia. And so then, yes, you can manage it by reducing the medications. And other times, if it's an off dystonia, which is the classic dystonia, is it's when you just in the mornings before you take your medications and it seems to respond once you start taking it, it gets a little bit better. then it's, oh, how do I get rid of the offs? Is there a way that I can take something long acting overnight that will keep me from getting dystonia in the morning? Or an inhaler that I use very quickly as soon as I get up to manage it. So there are ways of doing it, but DBS has a special efficacy as well when dystonia is becoming really bothersome and the traditional measures aren't really working.
Okay, we had Mr. Fowler. He probably wanted to ask a question, so I'm going to let him unmute if he has a question. Okay, I'm going to move on to Mr. Sharma here. Yes, Mr. Sharma. You'll have to unmute.
Did it work?
Yes, now it does.
Yes, thank you. My name is Pradeep, and I'm in 6 months in this whole exercise of discovering this particular problem. So I have been struggling for last some time. Is the amount of dose to be taken, and am I doing the right, or I'm just doing the approximation here and there and then taking it? I have been struggling on that. So previous I did hear your answer to a similar question, but I was not able to narrow it down in my head. What was the real answer? So if you can give me any guidance that for the dose to be taken, or uh, is there a reasonable way to calibrate that? Am I doing the right dose, right amount, right time, or just approximation? This whole exercise is an approximation. That's what I'm trying to understand.
So the honest answer is it's approximation and it's clinical. So the little guidelines that I give is, again, that, okay, we can figure out what too much is, and in that we should be humble about that, and sometimes we look and see if that is the way to figure this out. But frequently your neurologist also gets an opinion about how they feel you are doing. And is that consistent with when they see you in the clinic? Does that look like how you usually feel over the whole course of the day? Because that's an important component too. And so if they feel, just looking at you and having experienced other Parkinson's, it looks like it's pretty much good, then they can sometimes counsel you and say, you know, that looks like good function. I don't really have a high trust that we can get you to be better by increasing your dopaminergics, or they feel like there's some other side effect. But fundamentally, it's about figuring out the side effects, and sometimes people try Inbrija or inhalers to see if that kind of affects the clear, because you'll feel with those inhalers about 15 minutes after, usually the effect is there, or even shorter. And so, oh, this is what good feels like. So that can be a helpful tool as well. And then sometimes when people are developing this journey, it's hard to feel what off is like again. And so sometimes it's okay when talking with your neurologist about, oh, how about I hold the medication for a week, or I come down and see, okay, where do I end up? Or 2 weeks, how do I feel? And what does off feel to me? And then videos can sometimes help with these various things, but there's no easy thing. I mean, you can stick a wearable on and see what it says, but even then it's not enough.
So the bottom line is there is continue to do or do, I don't know what to say, continue to do some experimentation.
Yeah, so under the guidance, so the most important thing is that if you change things day to day, you won't have enough data. So under the guidance of your neurologist. So usually we say you make a change and then wait 2 weeks to collect data from after that change, because that's how long it takes. So there's a short effect of dopamine that comes within those minutes of taking it. And then there's the long effect that can last actually months, but we can't do that. That's research long. So we do clinically long. Usually most of it's felt within this 2-week to 4-week time frame.
Okay, We have someone saying here that they can attest to exercise, especially weightlifting, which has helped them tremendously in their tremor, as well as making them feel better throughout the day. So just wanted to pass it on to everyone else. And I am going to unmute Mac again. Yes, Mac, would you like to share since you raised your hand?
Yeah, sometimes it's difficult to know if symptoms are from Parkinson or something else. And you go to urologist for, because of urine problems, and you think that, but it could be from Parkinson's. So it's hard to know what to bring up and what not. We seldom have only one thing going on. But I have nervous legs at night, and I've come to the conclusion that it's a result of Parkinson.
Yeah. So the unfortunate truth is that Parkinson's does a lot of things, but Parkinson's doesn't do everything.
Correct.
And so you people can have multiple things. And so when you see the movement doctor, sometimes we'll just say, oh, okay, that could be Parkinson's. We'll try one of our meds. But I have generally a standpoint of, well, check with your primary care doctor and your other doctors too, because things come from other systems. So you can have urinary frequency. Parkinson's causes urinary frequency, sure. But also BPH or your prostate enlargement, and happens to a lot of older men. That happens, and so you should see a urologist and not just say, "Oh, that's my Parkinson's," or I'm having swallowing problems. That happens in Parkinson's. Well, I mean, you could have other things going on, and seeing the GI doctors are useful too. So just because you have a Parkinson's disease doctor doesn't mean you don't need any other doctors anymore. And I always remain cautious.
Okay, we have maybe time for two more questions. I'm going to wait for anyone to raise their hands or want to talk. But here, from the list, if you could share something, Dr. Hirczy, about taking medication with or without food, and how fatigue and symptoms like that can be reduced with food intake.
Yeah, so the standard statement, the party line that we pull is, oh, okay, take your pills an hour before your meals or 2 hours after. And that's the ideal way of doing it. And take it in a regimented fashion so that your meals are always at the exact same time of day and your medications are all at the exact same time of day. And that's great. But usually reality is it's a little bit more difficult, and some people experience notable nausea from that. And so sometimes there is an adjustment that happens, and it depends on the stage too. So sometimes people in earlier stages can actually take it closer to a meal or not really feel an effect from a meal. And so it's all about talking and being flexible. So and talking with your neurologist and seeing how it plays out for you, because everyone's Parkinson's is different. The stages are different, and how it's going to work it's different. So the standard statement, like I said before, an hour before, 2 hours after, and that works, but it's not required. That's not the only way that we can do it. And then about making that more impact from dietary sources. I don't have anything really there. Be on a heart healthy diet. That's good. And then again, I mean, I wouldn't recommend. We want you to have protein. We don't want you to be protein restricting, which is protein is the thing that blocks the absorption. So it's also something to talk about with your neurologist if you're on medications every hour or every 3 hours, and they're telling you, oh, wait 2 hours or an hour before. But is it possible? So how is this going to work out? And so we want you to be eating. We want you to maintain your weight. And so we have to have discussions about, okay, well, how do we do that? And do you need to be on a long-acting medication, or do we have to put the proteins or a protein shake at some point in the day and then the meds at another point? So, yeah, there are lots of things we can do to address those issues.
Okay, someone asked a question about what if they miss taking their levodopa? What can they do then?
Yeah. So it depends on the timing of things. We say you just take it when you remember to take it, but if you're feeling okay, and it's really hard to get your dose, then waiting until the next one, it's also can be okay. But sometimes if someone adjusts and they need these medications and they start feeling down, you just take it then because you're feeling the symptoms, and then you adjust your schedule after that point. So we standardly say 3 times a day, but then the more accurate statement is, every 5 hours, or what's the hour spacing to cover the daytime. So if it is, I missed the dose and I'm on every 3 hours, then okay, take it as soon as you can, and then adjust the rest of your doses accordingly to what you moved, how you moved it.
Okay, that's really all the time that we have today. Thank you so much, Dr. Hirczy. Is there any last comment or anything that you'd like to say before we end?
No, I mean, I was excited to be here and to talk, and I think this is very important. And I think that the fundamental takeaway from side effects is just data collection. So again, relation to your medications, video recordings if it's something that you can't get your neurologist to easily see. And then blood pressure logs and things like that. And again, the apps and the phone can help get all of that stuff so that you can look at it and then come to your neurologist with that information. Because usually the neurologist doesn't have a ton of time, and so they're pressed. And so if you can package it up nicely, like, oh, I did these things and I got this data, then you're going to get a lot more out of that encounter. If you come in and you're like, I'm not sure and I haven't done any of this stuff, then the neurologist, because I do it, I'd say, okay, go and collect all of that information. And then I didn't get what I wanted out of the encounter. I didn't make a change. I just got told to do some more things. And so I think that that's the takeaway.
Thank you so much. And I would add, as you had said a while ago, Dr. Hirczy, that my chart is a great way to contact and reach out to the provider as well. So with that, I am going to conclude today's session. Please do fill out the survey and let us know how you felt about this session. And if you have any additional comments or feedback, please do let us know. Thank you very much for joining us today, and have a great weekend.
All right.